Okay, let's shift gears now. Let's talk about diagnosis. So I want to talk to you about how to make the diagnosis of CHF. Is your patient truly in a CHF exacerbation? As you know, there is a broad differential diagnosis of dyspnea, including pneumonia, PE, pneumothorax, asthma, COPD, and many, many more. I gave you a little overview here of all the many findings in your history, physical, labs, chest x-ray, that can help you making the diagnosis. And it looks like a busy slide, but let me guide you through it. What I want you to pay attention to is likelihood ratios. Likelihood ratios are basically telling you if you have a positive finding, how much more likely does that make a diagnosis? In our case, a diagnosis of CHF. So let's start about history and physical. And organize our thoughts again in congestion and perfusion. You know those symptoms and signs already. We talked about them. So let's review how good they are actually. In terms of symptoms for congestion, if you have a previous history of CHF, it's probably likely that your patient has CHF again. So that gives you a likelihood ratio of 5.8. Initial clinical judgment is actually quite good. Researchers found out that if doctors have an initial clinical judgment that this is a CHF exacerbation, it makes it much more likely. Interestingly, classical symptoms like dyspnea, orthopnea, P&D are actually not quite as good because they're not specific enough. They would fit to all those other diagnoses as well, at least to a certain extent. On exam, remember your attendings always told you about the S3? This is why. Incredibly high likelihood ratio. Okay, if you hear an S3, that's a great sign that this patient has CHF. Also good signs are a JVP and a hepatojugular reflux. Again, kind of surprisingly, classical exam findings that we learn in medical school, like crackles, lower extremity edema, or presacral edema, are actually not quite as good as we think they are. All right, what about perfusion, cardiac output? Really, no high likelihood ratios in all of them. The problem is there's so many other good reasons why a patient could have low perfusion. The heart is not the only organ. We're going to talk a lot about that in our shock topic. But just remember the likelihood ratios for CHF are not quite as high. Okay, so what about our lab tests and our imaging studies that we use all the time? EKG. A good way to have at least a clue that this could be CHF is if you see atrial fibrillation. Has a likelihood ratio of 3.8. Okay, so it's about 4 times more likely. And the main reason is if your atria get dilated, then you develop atrial fibrillation. So it's a good sign that there must be some congestion going on. Chest x-ray, great. Likelihood ratio of 12. Okay, so that really helps you. If you see venous congestion on an x-ray, it helps you making the diagnosis. Cardiomegaly, pleural effusion, not that much. Venous congestion is clearly a better finding. Okay, lastly about the BNP. Often mentioned, often misunderstood. If you see with a rising BNP level, your diagnosis of CHF gets more likely, from 2.7 to 4.6. But compare that to a likelihood ratio of 12 or a likelihood ratio of 57. It's really not quite that good. The BNP is much better in excluding CHF because if it's less than 100, your likelihood ratio is 0.09, so it makes it much less likely to have a CHF exacerbation if you have a low BNP or a BNP less than 100. So that's why you will see medicine interns or cardiologists use the BNP to exclude heart failure, but not necessarily to make the diagnosis. All right, let's summarize it. What gives you most bang for your buck? A history of heart failure is good, all right? Likelihood ratio of about 6. Initial clinical judgment is not too bad. So if you have a gut feeling that this is heart failure, the data shows, at least to some extent, you can trust your gut feeling. Great exam findings are 3, JVP, and hepatojugular reflux. Not that much crackles and lower extremity edema. Chest x-ray helps, AFib on EKG helps, and BMP is really only good to exclude heart failure, not to make the diagnosis. Okay, once you make the diagnosis of heart failure, you want to find out, why does this patient have heart failure? What tipped this patient over? Okay, and I think about that as 4 sources of badness. And remember physiology. In physiology class, you learned that cardiac output is your stroke volume times your heart rate. And your stroke volume is dependent on preload, afterload, and contractility. All right? So all those things can tip you over in heart failure. And this shows this in a kind of an overview graph. Let's go to preload first. Preload means too much volume on board. Okay? This is the most common cause for a heart failure exacerbation. Often means either too much salt intake or too much volume. Remember, salt equals volume. We're going to talk about that in the hypo and hypernatremia lecture. Classic and probably the most common admission to the medicine ward for heart failure is medical non-adherence, not taking your Lasix dose. Or classically, the old lady in the retirement home who was stopped on the Lasix because her potassium dropped or her electrolytes were out of range. And then everybody thought about a lot of issues, but they didn't think about restarting the Lasix, and now she's in with heart failure. So this is a very, very common cause, just too much volume. Other causes is renal failure, worsening renal failure, missed hemodialysis sessions. I had a lot of patients who couldn't go to the hemodialysis when there was a lot of snow or when they didn't have a ride. So keep in mind, patients with renal failures are prone to volume overload. And often missed are what we do to patients, medications that we prescribe, NSAIDs. NSAIDs make you retain a lot of volume, okay? So this is the first thing you want to look at. Does this patient have an issue with preload? Next, afterload, all right? Afterload is a patient that comes in with a super high blood pressure, hypertensive crisis, and your heart has a very hard time pumping against this high blood pressure. Also, valvular dysfunction. A worsening aortic stenosis can tip a patient easily over into florid heart failure. Aortic stenosis gives you left ventricular overload. Also, think of more rare causes of heart failure, right ventricular overload, meaning something is in the lung that blocks blood flow through the lungs. And classical findings are COPD and PE. PE actually to a massive extent that you can go into cardiac shock. All right, so you check Afterload-Too. Next is contractility. Issues with contractility really mean there's too little muscle around to make the heart pump. Most important part in contractility is myocardial ischemia or infarction. You don't want to miss an MI in a patient that comes in with a CHF exacerbation. So you don't want to blame it only on your preload while this patient has an issue with contractility, because that's going to kill the patient. And if you miss it, you're going to have a very bad outcome. Also, worsening cardiomyopathy, and again, drugs and toxins. Alcohol, chemotherapy can tip somebody over into heart failure. All right, check contractility. Last one is heart rate. Often forgotten, very important. A patient with bradycardia or tachycardia, to a significant extent, will not be able to generate a good cardiac output. Also, atrial fibrillation. Atrial fibrillation, remember the atrial kick of the filling period of the heart? This really, in particular, if you have a stiff heart, a heart that endured a lot of hypertension, you need this atrial kick for filling. So if you're missing this atrial kick, this can tip you over into heart failure. So just to summarize again, if a patient comes in with a CHF exacerbation, don't only think about medical non-adherence or too much salt intake. Think about all those issues, okay? All those 4 different sources of badness, and try to be thorough so you don't miss a PE. You don't miss an MI, okay, and you don't missing new atrial fibrillation.